including neutralizing antibodies. Because of reduced immune responses with age, older adults are at increased risk of developing serious illness during RSV infection, which may lead to hospitalization or death. In the pivotal Phase 3 Renoir study, Abrysvo respiratory syncytial virus vaccine had a favorable benefit-risk profile and effectively reduced RSV-associated lower respiratory tract illness in adults 60 years of age and older compared to the placebo. Abrysvo respiratory syncytial virus vaccine is indicated for active immunization for the prevention of lower respiratory tract disease, LRTD, caused by respiratory syncytial virus, RSV, in individuals 60 years of age and older. RSV is a leading cause of respiratory infection worldwide in children under 5 years. Infants younger than 6 months are at increased risk of severe disease due to an immature immune system and are most likely to be impacted by severe consequences and hospitalization. Young infants rely on maternal antibodies for protection from infections. During pregnancy, maternal antibodies are actively transferred across the placenta to the fetus and can help to passively protect the infant during the first few months of life against various pathogens. Pfizer's Abrysvo respiratory syncytial virus vaccine was shown to elicit increased neutralizing antibody titers in maternal serum that were efficiently transferred across the placenta to the infant. In the Phase 3 Matisse study, Abrysvo respiratory syncytial virus vaccine administration to pregnant individuals showed a significant increase in protection against severe and non-severe medically attended lower respiratory tract disease through the first 6 months of an infant's life, and had a favorable benefit-risk profile in both vaccinated individuals and their newborns.
Abrysvo respiratory syncytial virus vaccine is indicated for passive protection against lower respiratory tract disease caused by respiratory syncytial virus RSV in infants from birth through 6 months of age following maternal immunization during pregnancy between 24 to 36 weeks of gestation.
Assalamualaikum warahmatullahi wabarakatuh. Selamat malam, Om Swastiastu, Namo Buddhaya, dan salam kebajikan bagi kita semua. Puji dan syukur kepada Tuhan Yang Maha Esa. Karena atas rahmat dan karunia-Nya kita dapat menyelenggarakan acara KOPI POGI, kajian online penyihatan ibu dengan judul Understanding RSV Impact in Infants, What Should We Do? Izinkan saya memperkenalkan diri, saya Dinda Nur Cahya, selaku MC pada acara pada malam hari ini, mengucapkan selamat datang dan terima kasih kepada Profesor, Doktor, dan Dokter, juga pada pengurus pusat PP POGI beserta jajarannya yang telah hadir, dan juga pada narasumber dan moderator kami yang telah berkenan menjadi pengisi acara pada KOPI POGI pada malam hari ini. We should also like to extend our warmest greetings for Professor Jamiah binti Hasan for graciously joining us and delivering today's presentation. Serta yang tidak kalah penting saya ucapkan juga selamat datang kepada seluruh peserta KOPI POGI pada hari ini. Baiklah, marilah kita mulai acara kita, KOPI POGI Understanding RSV Impact in Infants, What Should We Do? Dengan pembukaan sekilas pandang KOPI POGI yang akan disampaikan oleh Ketua Bidang Ilmiah PP POGI, Dr. M. Alamsyah Aziz, spesialis obstetri dan ginekologi, subspesialis kedokteran fetal-maternal, subspesialis terapi intensif, Magister Kesehatan, International Affiliate of the Royal Australian and New Zealand College of Obstetrician Gynecologist, Fellow Minimal Access Surgery. Dengan CV, kepada yang terhormat Dr. Alamsyah, waktu dan tempat saya persilakan.
Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Yang kami hormati Ketua Umum POGI yang hadir pada malam hari ini, Prof. Yudi, beserta dengan seluruh guru besar yang hadir, Prof. Yopi, dan para senior serta sejawat yang hadir. And thank you for Profesor Jamiah for join us this night. Ya, pertama-tama kami mengucapkan terima kasih atas kehadiran seluruh peserta pada malam hari ini. Dan ini adalah kegiatan KOPI POGI, ya, jadi kalau kegiatan kafe, jadi KOPI POGI, ya, jadi KOPI POGI yang memang biasa kita laksanakan setiap bulannya. Dan alhamdulillah bidang ilmiah sudah menyelesaikan kegiatan KOPI POGI 23. Selama sepanjang kepengurusan yang terakhir nih dari Prof. Yudi sampai dengan bulan Juni ini kita telah menyelesaikan 23 kali siaran, ya, jadi siaran secara online, Prof. Jadi 23 kali, dan ini adalah kegiatan terakhir dari KOPI POGI yang kita laksanakan secara hibrid, ya. Jadi memang pesertanya ada yang melalui Zoom, dan yang saat ini hadir di sini adalah terkait dengan kegiatan simposium yang sudah kita laksanakan, dan insya Allah pada malam hari ini akan kita laksanakan secara hibrid. Dan kami mohon agar mungkin seluruh peserta yang hadir nanti dapat menyimak dengan baik dan berdiskusi. Terima kasih kepada Dr. Rima yang sudah bersedia menjadi moderator pada malam hari ini. Dan tentunya dari teman-teman nanti yang dari Zoom, ya, kami harapkan banyak pertanyaan, ya, sehingga nanti banyak sekali pertanyaan yang bisa kita sampaikan pada Prof. Jamiah. Baik, dengan tidak membuang waktu, kami mohon nanti Prof. Yudi untuk membuka kegiatan ini. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih kepada Dr. Alamsyah. Saya undang untuk Prof. Yudi untuk dapat memberikan kata sambutan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat malam, salam sejahtera, Om Swastiastu. Yang saya hormati, of course, our guest speaker from Malaysia, Profesor Jamiah. Sorry ya, terlalu malam. You look too tired. Tapi alhamdulillah, Profesor Jamiah nyaman di Bandung ternyata. Mungkin nggak mau pulang dia. Prof. Yopi dan para hadirin sekalian Pogja infeksi, teman-teman. Alhamdulillah wa syukurillah. Mungkin tadi Prof. Jamiah menanyakan apa itu KOPI POGI. Jadi POGI ini mempunyai media untuk bertemu dengan para anggotanya. Kami punya anggota kurang lebih sekitar 5.800 sekarang, hampir 6.000 ONG di Indonesia. Sulit kita ketemu untuk dalam 1 tahun di dalam pertemuan ilmiah annual meeting ya POGI itu sulit, paling sampai hanya maksimal 4.000 itu pun kalau di kota-kota besar. Bandung, Jakarta mungkin mampu untuk itu, tapi di Manado, di Palembang itu susah untuk mencari tempat yang dapat menampung anggota POGI 4 million more ya betul kan? Ada satu lagi HOGI, Himpunan Onkologi Ginekologi. Itu media bertemunya ONG dengan para pakar dari gynae oncology. Ada lagi, Veto mungkin ada nanti. Itu media-media sebetulnya yang kita bangun untuk supaya bisa berkomunikasi dengan para ekspertis. General Obstetrics Ginekologi dengan subspesialisnya. Nah pada hari ini KOPI POGI, tadi Dr. Alam sudah berapa kali kita mengadakan ini, memang seringnya adalah berupa Zoom. Sekarang alhamdulillah bisa kita hibrid karena ada kegiatan beberapa kali hibrid. Oleh karena itu mudah-mudahan kita explore, ada ekspertis dari Malaysia, suruh Prof. Jamiah nanti keluarkan tuh ilmunya semua. Jangan sampai berudul tapi rambutnya nanti. Mudah-mudahan kita sering beginilah sharing ya, between Indonesia and Malaysia maybe ya, for the future. Karena memang kita serumpun, tak bisa bahasa Inggris, bahasa Melayu pun jadilah. Gitu. Karena memang saya pernah lecture di UKM menyampaikan tentang minimal invasive surgery in gynae oncology kan gitu. Ternyata pas ngomong bahasa Indonesia banyak juga mereka bahasa Melayu, ternyata tanyanya banyak. Ya udah susah-susah bahasa Inggris belepotan gitu. Beda kalau Malaysia. Second language kan jelas Inggris. Kalau mungkin Prof. Yopi yang dulu, tapi zaman saya dulu sekolah, maaf ngomong, mungkin Prof. Yopi saksi hidup itu. Ada senior saya, sampai kita diundang guru bahasa Inggris namanya Tina Dewi Judistiani. Dulu ngajar bahasa Inggris kita. Saya ingat sekali, ada teman saya dimarahi oleh Prof. Yopi. Pakai bahasa Inggris, ketawa-ketawa dia. Karena tidak ngerti bahasa Inggrisnya, kan gitu. Begitu dijelaskan, kamu diam ya, karena Prof. Yopi sedang marah. Langsung diam kan. Terus ditanya lagi, masih nggak bisa. Begitu ditanya oleh Prof. Yopi, pakai bahasa Indonesia, Prof. Herman dulu. Pakai bahasa Indonesia, oh yes. Jawabnya cuma bisa, oh yes. Itu zaman saya, saking bahasa Inggris cuma pinter tuh I love you. Ya itu ya. Yang mudah-mudahan sekarang kita bisa explore semuanya. Ya. Prof. Jamiah ini ada di sini, nanti Dr. Rima untuk moderator. Mudah-mudahan kita diberikan masukan ilmu yang cukup baik dan kita selalu sehat walafiat. Demikian, bila taufiq wal hidayah. Wassalamualaikum. Dengan demikian secara resmi KOPI POGI secara hibrid kita buka. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih saya ucapkan kepada Prof. Yudi dan Dr. Alamsyah karena telah membuka acara ini. Sebelumnya kami ingin menginformasikan kepada para peserta mengenai peraturan pembelajaran LMS untuk mendapatkan SKP. Saya mengingatkan kembali bahwa pembelajaran KOPI POGI di laman pelataran sehat sistemnya tertutup. Sehingga sesudah acara kami akan input peserta yang hadir berdasarkan absensi. Dan dimohon untuk ditunggu dalam kurun waktu maksimal 3 jam hingga setelah berakhirnya webinar. Peserta yang terverifikasi akan mendapat email dan atau jika belum mendapat email dapat membuka halaman pelataran sehat dan mengklik notifikasi di pojok kanan atas. di masing-masing akun peserta untuk melihat notifikasi pembelajaran. Masa pembelajaran berlaku selama 24 jam. Pihak panitia tidak akan menerima komplain atau permintaan untuk membuka akses pembelajaran jika sudah melebihi dari 24 jam. Sehingga pastikan peserta webinar sudah mengklik mulai belajar jika sudah mendapatkan notifikasi. Kemudian, dalam memberikan pertanyaan, dapat dilakukan di kolom Q&A yang tersedia dan bukan di kolom chat. Hal ini agar mempermudah narasumber untuk menjawab pertanyaan yang diberikan. Untuk pertanyaan selain materi yang telah dipaparkan, dapat ditulis dalam kolom chat. Selanjutnya, kita akan memasuki sesi ilmiah yang akan dipandu oleh Dr. Rima Irwinda, spesialis obstetri dan ginekologi, subspesialis kesehatan fatomaternal. Izinkan saya membacakan CV singkat dari moderator kita. Baik, Dr. Rima Irwinda memulai pendidikan kedokteran di Fakultas Kedokteran Universitas Indonesia pada tahun 2023. Baik dok, saya persilakan.
Terima kasih, selamat malam. Assalamualaikum warahmatullahi wabarakatuh. Kepada Prof. Yopi, Prof. Yudi, dan our distinguished guest, Prof. Jamia, dan juga para senior dan teman sejawat yang telah hadir pada malam ini. Mungkin lelah, tapi mungkin kita excited juga mau mendengarkan dari Prof. Jamia mengenai RSV impact to infant and what should we know and what should we do. Dan pada akhir acara nanti kita akan lebih banyak diskusi. Kalau mau ada pertanyaan atau komen silahkan. And currently we already have 200 participants in Zoom, and the participants are different from the participants in Seminar Nasional. So I think you should repeat your presentation, even though we already hear your beautiful presentation early in this morning. Is it okay, Prof. Jamia? Ya, ini adalah CV Prof. Jamia. Prof. Jamia adalah konsultan dan fetomaternal Departemen Obgyn di University Technology Mara dan juga kepala fetomaternal di Hospital Al Sultan Abdullah. Mungkin saya tidak perlu baca satu-satu ya, Prof. ya. Ya, without further ado, please Prof. Jamia to give talk.
Thank you very much, Dr. Rima. Assalamualaikum. Good evening, ladies and gentlemen. Thank you very much for the invitation from Dr. Lamsha and POGI and Prof. Yudi. This is a coffee talk, but it's not too late to do a coffee talk. And I'm going to give you a lecture on, I hope to have some discussion afterwards, on RSV vaccine. Now can I have my slides? Do you have a pointer? I'd also like to welcome those people online. Thank you very much for joining us online. It's such a late time on a Saturday night, and thank you very much for learning together with us. So what I'm going to do tonight, I'm going to talk a little bit about the data and guideline about RSV vaccination for pregnant mothers. But I do realize there's some people who are not here this morning, so I'll just cover some of the basics on the RSV. Do you have a pointer? No? This is my disclosure. Now, even a lot of the slides are from Pfizer. I just like to make, I don't have any conflict of interest. Whatever I said has not influenced by Pfizer, so it all comes from my own opinion. So next slide. So I'm going to give you an overview about the vaccine history and talk a little bit about the immunology in pregnancy and say why maternal immunization is very important. Then I'm going to zoom on into the RSV specifically, talk to you a bit about the burden of the disease, and then give you some data on RSV maternal immunization and why we should consider RSV maternal vaccination, and then we conclude from that. Next slide. Now, when we talk about maternal immunization, it's not something new. I'm sure you remember from the school days about smallpox. So we have been having smallpox for more than 100 years. So that's the first thing we learn about vaccination. Now, if you remember, there's two very important strategies in public health in terms of improving the health of mankind. One is clean water, the provision of clean water. Second is vaccine. So more than 100 years, these two important public health strategy has been with us to save mankind. But you look at maternal immunization, it's not something new either. We know about tetanus vaccine. That has been with us for more than 70 years. So when we talk about vaccine, nowadays we are more familiar in vaccine simply because of COVID. If you remember COVID, not very long time ago, it kills millions of people around the world, but it also kills pregnant mothers. So in Malaysia, if I can reflect a little bit in Malaysia, when COVID came in Malaysia, when the vaccine was approved by the government, the pregnant mothers were excluded from the COVID vaccine. Within 6 months, we had more than 50 mothers died with COVID. And by the end of the year, we had slightly more than 60 mothers died by COVID. Then the government changed in terms of recommendation. Quickly enough, the vaccine was also recommended to pregnant mothers, and we gave to all pregnant mothers. After we gave the vaccine, none of our pregnant mothers died from COVID. So that's a very important lessons from us. So it's not something new. When we talk about RSV, as an OBGYN, I don't think you see any RSV patient. Most of the RSV patient will be the pediatric pool. So they'll be seen by the pediatrician or the neonatologist. So as an OBGYN, RSV will not be something that you see in your normal patient. But when we talk about RSV vaccine, it's not something new either. If you look at this slide here, the first study about RSV maternal immunization was about 2012. So it's not something new. It was more than 10 years ago. It's just that to fine tune the vaccine is not easy. So now for recommended vaccine in pregnancy, which is COVID, then we have influenza, we had Tdap vaccine, and now we have RSV. So it's not something new. We built the idea of vaccination, the confidence of vaccination from the successful vaccination of tetanus. And you know, worldwide, WHO has made a strategy for elimination of tetanus. And we have sort of reached elimination in more than 60 countries. So that's a very important thing to remember, because vaccine saves women and also saves the newborn. So now I heard this morning about the tetanus in Indonesia is also at a low level. So that is something that's important. So it's not a new concept. But we know pregnant women can die during pregnancy, of course, can die during delivery from other things. But we also know that pregnant women has slightly reduced immune system. They're slightly hypoimmune. Why is that so? Because you and I know that the fetus is semi-allogenic. 50% of the fetus genetic material come from the father. Therefore, the woman needs to protect the fetus, not to reject the fetus. So the immune system must change. So there is 3 distinct immune phases in a pregnant woman. So it's divided into the first trimester where the immune system will be cellular based. So in this time where there is implantation of the zygote and formation of the placenta, during the implantation, you need an inflammatory environment. So that be a cellular based vaccine, immune system. But in the second trimester onwards, the mother immune system must change to an antibody-mediated immune system, a type 2 environment. And this will maintain right up to just before delivery, where it will go back to a cellular environment. So it will change to a Th1 immune environment. So therefore, because the mother has slightly an hypoimmune, so they are more exposed to infection, especially in pregnancy. If you remember, influenza during the H1N1 pandemic, if the mother acquire influenza infection in pregnancy will increase her risk of hospitalization, ICU care, especially if she had the influenza in the 3rd trimester. And influenza infection also increase the risk of stillbirth, small babies, and preterm labor. So that's something we know because it's an inflammatory condition. So it's very important for us to protect the mother, but we also want to protect the newborn because every pregnancy is a celebrated pregnancy. Everyone wants a healthy wife and a healthy newborn. Therefore, it's a gift of life to protect the newborn with antibody from the mother. That is something natural. So when the mother is given vaccine, any vaccine, she will mount a vaccine-specific immunity. And this antibody, for the time you give the vaccine to the pregnant mother, it will take about 2 weeks for them to mount an antibody. Now, this antibody will pass through the placenta to protect the newborn. And it also can protect the fetus inside the uterus while the patient is pregnant, because we know that whatever infection goes to the mother will go through the transplacenta to the fetus. So when you see this particular slide, you see that the first the only IgG that passed through, the immunoglobulin that passed through is immunoglobulin G. There is 4 subclusters, and IgG1 has the most efficient passage through the placenta to the fetus. So the IgG has first been seen to transfer transplacentally about 13 weeks or so. By about 20 weeks, more than 20-30% of antibody transfer. By the time you reach in the 3rd trimester, there's more antibody transfer. That is in the other graph. On the right side, you see the fetal-maternal ratio at birth. So as the gestational age advances, there's more antibody transfer. And by the time the baby is born, the antibody in the cord blood supersedes the antibody in the mother. So when you give the mother vaccine, she will mount an antibody within 2 weeks, and this will be transferred to the fetus. Now, the longer the phase of transfer, the higher is antibody. But of course, in the 3rd trimester, the antibody production is much higher because the FcRn, the FcRn receptor, that is the transport, the antibody, the immunoglobulin transplacentally is highest in the 3rd trimester. So that's an important concept. So now let's go dive in RSV. As I said just now, as an OBGYN, we do not see RSV patient. But we know that RSV is one of the most important cause of hospitalization among children worldwide. And about 60% of pneumonia are caused by RSV. So if you look at RSV, you look at the R0 of RSV is 4.5. So, and if you look at the R0 of influenza is 1.3. So RSV R0 is much higher. So one person who get an RSV can infect another about 4 other persons. So that's important. And if you look at this slide, RSV accounts about 2/3 of acute respiratory infection among infants and young children, especially under 5 years old. So you see 63% has been estimated by WHO of infection are caused or admission are caused by RSV, respiratory infection, so on. So where do we come from there? And we know that maternal immunization has been shown to be one of the most highest impact to protect the newborn infants. And therefore, we should build on this. So if you give an RSV vaccine to the mother, then she should mount an antibody to protect the young infant. So it's similar to any other vaccine, like for example, influenza vaccine or tetanus vaccine or Tdap vaccine. So the criteria is, so the mother being immunized, so she produces antibody, and in this case, we're talking about RSV vaccine, which is the bivalent prefusion F vaccine, and this will produce an immune response by the mom and the antibody transfer. So now let's talk a little bit about data. Because when we talk about something like maternal immunization, one of the questions that people will ask, how safe is the vaccine? One. Second is, how efficacious is the vaccine to protect what we said it was supposed to protect? So we have to believe somewhere in science. So we need to look at data. So if you look at the RSV initial trial, so initially the trial started in 2018 in the phase 1, phase 2, where those finding trial. But what is important to us as OBGYN is the pregnant mother in the trial. If you look at a lot of trials, they always excluded pregnant mothers in the trial because of the concern of the fetus. But CDC and WHO now already made a statement we should include pregnant women in trial to see what's the impact, especially when we want to give certain drugs or vaccine or to the pregnant mothers. So let's go and dive at the Matisse trial. The Matisse trial is a maternal immunization study to evaluate the safety and the efficacy. So when you look at Matisse trial, in the phase 3 trial, where it's include the pregnant woman. This doesn't move. Can you move the slide for me? So the Matisse trial is a global study which is in 18 countries. So they have more than 7,000 patients in the pregnant, in the Abriso arm, in the RSV prefusion F arm, and they also have another similar number of patients enrolled in the placebo arm. And the next slide, please. So in this maternal infant, the participants were evaluated for the side effect to look at the safety data, what they also want to look at the efficacy data. So it started in June. So they enrolled pregnant women that's less than 49 years old from 24 to 36 weeks. So that's quite a wide range of gestational age. So they wanted to look at the efficacy and safety. So the initial data cutoff was September 2022, and now the 2023 October, that is a 24 months of post-trial. You see here is the vaccine, the Abriso is into the placebo is 1:1 ratio. So the number of participants is almost the same. So let's look at the safety data. Next slide, please. Cannot move. So if you look at this Matisse trial, so you see here, so we have just again to show you from June to 2023, where the final safety data follow up, and we had more than 7,000 participants. Next slide, please. It doesn't move. Can I have the next slide, please? So let's look at these particular data. Slide before. So this is the pregnancy outcomes, and they were balanced between the vaccine arm and the placebo arm. So if you see here, so one of the things to look at this is the time between vaccination and delivery. What does it mean? The time from the time they take the vaccine on the pregnant mother to the time the delivery, because one of the concerns is preterm delivery. So the average days is about 50, and the range from 25 to 96 days, 25.96. So when you look at data, the earliest time that the vaccine to the delivery time is about 4 weeks. This is about 4 weeks. So this one is average about 57 days. So the gestational age at delivery mainly is about 39 weeks. And the delivery outcome, vaginal, is about 2,577. Then cesarean section, there's 1,090. When people always ask, does the vaccine increase the rate of cesarean section? It's not very easy to say that because there are other compounding variables to that. Why cesarean section is done, not specifically due to the vaccine. So there's emergency cesarean section, about 249. And you look at the maternal death and fetal death, and the sub-analysis to that, it was found it's not related to the vaccine. So invariably, the pregnancy outcome were quite balanced between the vaccine arm and the placebo arm. Next slide, please. So when you look at the infant outcome, this is where you want to dive into the preterm birth. Was it comparable between the placebo and the vaccine arm? Now, this data is up to 24 months 2 years after. So you look at the premature birth, less than 37 weeks is comparable between the vaccine arm and the placebo arm. Again, the preterm and the low birth weight is also comparable. And if you look at the severe the side effects, adverse events related to hospitalization in the neonatal period is also comparable to. So there is no safety signal as yet that we can see from the vaccine RSV that has been given to the pregnant woman. Do you have this? Next. So this is the birth outcome between the two cohorts, the vaccine arm and the placebo arm. It is also compared. You can see here majority are the term birth. So the term birth and the normal birth and the weight are also comparable between the two arms. Next. Can you go back? Just before? Okay, next slide, please. Next slide. Now, this one is looking at the countries which is participating in the trial, Matisse trial, the 18 countries. So if you look at the countries, the one that crosses zero is not significant in terms of preterm birth. The only country that has slightly more preterm birth is South Africa. So that is 39 in the vaccine arm versus 19 in the placebo arm. That's the only one. But when you look at South Africa, you look at the other compounding variable that may increase the risk of preterm birth. So it's not necessarily related to the vaccine. And next slide, please. So this is looking the Abrysio, the RSV prefusion vaccine. You see demonstrated high efficacy against RSV positive severe medically attended lower respiratory tract illness in infants from birth to 6 months. You look at here from 0 to 90 days, the efficacy is more than 82%, and up to 180 days is 70%. So that tells us that the vaccine efficacy is good. That's next, to protect the baby from the birth to the infant. Next slide, please. So this is looking slightly different. It's the same. They're looking at the graph in the placebo and the vaccine group, the Abrysio, in the infants from the days of 90, 120, 150, 180. The next slide, you will see there is an incremental protection. Next slide, please. So you see here, between the placebo arm, the further you go, so the wider is the separation. So that demonstrates there's an incremental efficacy as time goes by in the vaccine arm in the protection of from birth to 6 months. Next slide. So this is the same. It's going back. Next slide. This is the efficacy also demonstrated again. The RSV-associated medically attended lower respiratory tract illness is the same. You can see that the efficacy is still maintained up to 180 days, and you can see that as the time further goes away, there's a wider separation between the placebo arm and the vaccine arm, showing incremental efficacy of the vaccine. Next slide. So in the summary, so it's the same, the summary as I said before. So the efficacy shows that the vaccine is efficacious in protecting the infant from birth through the 6 months of age when we'll give it to the pregnant mother during pregnancy. Next slide, please. And you have to remember this particular study, they give the vaccine from 24 weeks to 36 weeks. So this is just a summary of the Matisse study. So we know that the RSV is a leading cause of lower respiratory tract illness among infants globally, and we know that it causes 50 to 80% hospitalization for viral bronchiolitis globally. And we know that Matisse study has shown that the vaccine efficacy is up to 82% in 3 months and up to 69% in 6 months. So it's still substantial vaccine efficacy up to 6 months. Next slide. So this is, again, is just to show you a summary of the bivalent prefusion vaccine in terms of safety profile. So the safety profile is quite comparable between the vaccine arm and the placebo arm in terms of preterm birth. And you can see that in some of these, none of the severe adverse events or death were considered as related to the vaccine. And in pregnant individuals, the most commonly reported adverse events are just pain at injection site. So it's quite, in the preterm, is balanced between the vaccine arm and the placebo arm. Next slide, please. Again, this shows that the post-hoc analysis suggests there's no significant increase in preterm birth. So this is something that people always ask, even in Malaysia, they ask, so what is the increased risk of preterm birth? And we see that from the data now, 24 months after the initial analysis, is shown that there is no difference in preterm birth in the vaccine arm. So if you look in the Asia-Pacific preterm arm, so if you look at the Matisse study sub-analysis, in the Asia-Pacific, the rates of preterm birth is higher in the placebo rather than the vaccine group. And in Japan also said about the same. Next slide, please. So this is just to show you that there are more than 50 countries that approved the RSV vaccine globally, including Malaysia and Indonesia. Indonesia had the vaccine approved last year, I think, December, and Malaysia had it approved recently. Next slide. Right. Just now we look at the Matisse trial. So Matisse trial is in a very controlled situation. Healthy infants, healthy mothers, which is enrolled in the study, following exactly as the study protocol. Because you know, vaccine studies are not easy to do, because you have to follow every protocol, and the vaccine must be controlled in a certain situation. The cold chain must be maintained all the time, and the patient, if there are any risk factor, they're excluded. So we need to look at real-world data. Real-world data where the vaccine is used in a real-world fashion to see whether or not the efficacy of the vaccine in real-world data is the same in the trial, like in this one is Matisse trial. So this is the Bernie trial. So the Bernie trial, so Argentina was the first country in the world to approve the use of the prefusion RSV vaccine, RSV prefusion vaccine, the RSV vaccine, the only vaccine which is approved by CDC in Argentina in 1st of March 2024. So they approved it. Why I think Argentina approved it quite quickly? Because in Argentina, the RSV causing pneumonia, bronchiolitis, hospitalization is quite substantial. They spend about 25 million per year in taking care of infants or children admitted from RSV vaccine. And the prevalence of RSV in Argentina was about 47 per 1,000 children. So that's pretty high. So they approved the vaccine. So what they did was they wanted to see the efficacy of the vaccine. So this is a retrospective analysis. And this is passed by ethics. So this retrospective analysis, so 12 hospitals participate in this. So what they wanted to do is, they wanted to evaluate the vaccine effectiveness, which is the RSV pre-fusion vaccine, which is approved during pregnancy, which is given to their pregnant woman. But so they had 1 year. By the time they analyzed the data, they had more than 60% of their pregnant women who had received the vaccine. So next slide. So here, what the study design was, so this is a retrospective study. So they identify all infants which is hospitalized due for lower respiratory tract illness. And they send the blood to check for all panels. So they check for RSV, influenza, parainfluenza, rhinovirus, and so on, to see which are the causation of the LRTI infection. Then they classify the infant as case control. So, and they, based on the lab test result, case negative and also case positive. And they look at the case negative, whether the mother had been vaccinated or not, and the case positive, whether or not the mother had been vaccinated or not. So that's a big cohort. So 12 hospitals participated in this one. So then they analyze the data. Let's just look at the next slide. So this is a quite complex case. So what they had was, during that 1 year, from the first month, from the time they approved the RSV vaccine, they have 505 infants which was hospitalized for lower respiratory tract disease, which is comparable to the illness. And they were included in the study, and this was across 12 participating hospitals. So if you look at the infant age and so on, so that's on the far left there. So when the infant is hospitalized, when they check, so they look at the case positive RSV, 286 from out of 505, and they had a control infant, a case negative. So then they backtrack and look at the mother. So the mother who has received RSV pre-fusion F during pregnancy was 70.8%. And the mother who did not receive was 82.2%. On the other one was case negative. So the mother that received the vaccine was 109, and did not receive the vaccine was 110. And they analyzed this to see the vaccination efficacy. So let's look at the next slide. So here, it's very difficult for me to look from here. So the effectiveness of maternal RSV pre-fusion vaccine during pregnancy here. So up here you see 286 cases was positive, 219 was negative, and 17.8% case infants were born to RSV pre-fusion vaccinated mom, and 49.8% were born to RSV vaccinated mothers. So the negative and the positive together. So what did they find? So they find that here, so this is the vaccine efficacy against RSV-associated LRTD, leading to hospitalization, and RSV-associated severe LRTD, leading to hospitalization among infants from 3 months to 6 months. And they find that the vaccine efficacy is effective, it's 78%, and also ranging all the way, so it's all the way protective, 76, 70, 71.3, and 78%. So what the study shows that the vaccine in a real world event has similar efficacy to what has been shown in Matisse. So it's following a similar trend. So let's see, the next slide, please. So it's comparable to Matisse. So there would be more studies in later on. There are some studies in the pipeline if you read the literature. So what this study summarizes is the real world data shows that it is efficacious. The vaccine efficacy remains similar to the Matisse trial. And this analysis is sort of reassuring to us to show us that the vaccine is efficacious. So it shows that 78.6% effectiveness against RSV-associated LRTD, leading to hospitalization from birth to 3 months, and 71.3% up to 6 months. And the same thing, similarly, 76.9%, RSV-associated severe LRTD, leading to hospitalization from birth to 6 months of age. So this is an important study. Next slide, please. I've shown you just now this national recommendation. So if you look at this national recommendation, so you see here most countries would recommend the RSV vaccine from 32 weeks to 36 weeks. That is what CDC recommends. But there are some countries like United Kingdom initially started with 32, now they have moved to 28 weeks. Australia is now a year round from 28 to 36 weeks. But Slovenia and some other countries, 24 to 26 weeks. So in Malaysia, our recommendation was also 32 to 36 weeks. Next slide, please. So as healthcare providers, we we have to sort of be more confident in provision of vaccine. So studies have shown that if the healthcare providers are not confident in not confident in the data or do not trust the data, the chances are we will not recommend it to our patient. And the patient will look at the healthcare providers for recommendation and guideline. Because if the healthcare provider has concern about safety, efficacy, so has the patient. The patient also has concern about safety and efficacy. Therefore, it's important for healthcare providers to educate ourselves to ensure that we are able to address the misconception or the question from the patient. So we have to sort of to provide the guidance to the patient. So if we believe in the vaccine, there's a chances are the patient will trust us. But of course, there are we need to answer some of the question queries. So it's very important to introduce the vaccine right from the antenatal visit, the first antenatal visit, and normalize vaccination as part of the antenatal care. Next slide, please. Well, there is some slide missing. See this next slide? Is there any other slides? No. All right, never mind. So in CDC, CDC in June 2024 has published the updates on the RSV vaccine worldwide. So what they do, they have this various reporting system in CDC. So in US, so it's very important. So everybody needs to report to the various reporting system for any side effects or anything that's related to vaccine. So in June 2024, the CDC has written a write-up on the update on the vaccine. At the point of they wrote the report, the more than 300,000 vaccine was given to the patient, to the pregnant mothers, and they did not find any increase in preterm birth. And they also did not find any increase in adverse outcome. So their conclusion was, in that time, was the vaccine does not increase the risk of preterm birth. We can discuss about that in a moment. So in summary, the vaccination in pregnancy is an important strategy. I think it's an important strategy because we have the capacity, the women have the capacity to give the gift of life, which is the maternal antibody to protect the infants, the newborn infants. And RSV burden is high among infants. The only important strategy, one of the important strategy is maternal immunization. Of course, the other strategy too is vaccinate the infants. But even if we vaccinate the infants adaptive immunity still needs to work with the vaccine. And in young infants, the adaptive immunity may not be as robust to produce the antibody. Therefore, maternal immunization is one of the important strategies to protect the young infants. So information and administration of the vaccine in pregnancy needs to be integrated in the antenatal care services so that the mother is normalized into part of the antenatal care. Next slide. I think that's the end of the slide. So I just put a quote here, which I think is important from Neil Armstrong. It's one small step for the man, but it's one giant leap for the mankind. We're here to protect the newborn who have the rest for many, many years to come with maternal antibody. Thank you very much. Just sit.
Thank you for Jamia for fascinating presentation. Before we start discussion, I would like to inform partisipan yang ada di Zoom, mohon kalau ada pertanyaan bisa mengetik di Q&A, nanti akan kita bacakan. Sebelumnya ada beberapa highlight yang ingin saya berikan setelah Prof. Jamia presentasi. Yang pertama adalah Kalau saya lihat dari presentasi Prof. Jamia, ada perubahan fisiologis pada kehamilan yang bisa kita pertimbangkan kenapa pada ibu hamil resiko infeksi terutama pada trimester ketiga lebih berat. Yang kedua adalah pada saat kita memberikan vaksin yang perlu diperhatikan tujuan, kalau RSV terutama untuk janin, sedangkan efikasinya baik metis maupun berni 80% untuk 90 hari, dan untuk 180 hari kurang lebih 70% dan safety-nya kurang lebih aman meskipun preterm ada lebih tinggi 1% tapi tidak bermana secara signifikan, tapi mungkin nanti akan bisa kita diskusikan. Mungkin silakan Profesor dan Dokter kalau ada pertanyaan bisa diajukan sambil menunggu yang ada di Zoom. Silakan.
Thank you very much for your nice and very clear presentation. Before I ask my question, I would like also to explain that KOPI POGI is mean POGI KAFI, but it's actually an abbreviation. KOPI stand for Kajian Online Penyegaran Ilmu. So online study for refreshed knowledge. So online study for refreshed knowledge, something like that. My question is about, so thank you very much because it's around 200 is in Zoom. How many? 275. Very nice. Actually, this is very fresh presentation for us. My question is the study from Bernie, something from Argentina. It's a case control study, right? But you usually, when you perform case control study, we like to see the odds ratio the odds ratio. But it's explained by efficacy like 70 or to 80%. But maybe you have the idea of how many or the odds ratio, because it means the risk or the risk or the prevalent risk, preventive risk. I mean the preventive risk of giving vaccination, to mother to prevent influenza or virus.
Prof, I think this one, they don't use the odds ratio because they calculate it in a very complex logistic regression calculation because they use a negative case. So it's on a retrospective cohort, not a prospective cohort. So they have to follow their ethics approval. So that's why I think they don't give you that odds ratio calculation. Because if you look at the vaccine efficacy calculation, it's also very complex.
Thank you. Do you have an idea the difference of prevalence of influenza, seasonal, in Europe or in Asian countries?
I can tell you in Malaysia. So in Malaysia, the seasonal RSV is about mid-year, somewhere between August, October. So that's where the peak is. So there are a few studies looking at it. So we are not all the year round, but the peak ranges from there. So like influenza is all year round, the perennial. So RSV is slightly in the middle year in our country, according to one of the study. So, but a lot of the countries now, the RSV vaccine, they're not seasonal, they all year round. The recommendation is not seasonal anymore. In the Bernie study, they gave the vaccine prior the season and during the season. So it's not seasonal. So now most recommendations are moving away from the seasonal. So it's year round. So we are not giving seasonal. So we are all year round. That's our recommendation.
Thank you.
Tapi kalau ada soalan dalam bahasa Indonesia atau bahasa Malaysia, saya boleh cuba jawab. Lebih kurang sama saja. Kalau takut ada soalannya yang mau ditanya dalam bahasa Indonesia.
Ada pertanyaan lain di online belum ada tadi saya lihat, tapi mungkin mengenai data di Jakarta, Prof, mengenai RSV pada anak, ini datanya memang masih limited, tapi mereka sedang mengumpulkan dari beberapa rumah sakit RSV. Dan data yang terkumpul sekarang yang paling banyak adalah Oktober sampai Maret. Datanya tingginya Oktober sampai Maret. Mungkin kurang lebih sama ya, Prof ya?
Hampir sama.
Hampir sama ya kurang lebih. Is there any other question? Jangan malu-malu. Udah kayak pengen mau nanya.
Saya dalam bahasa saja. Pertanyaan saya pertama adalah bahwa tanpa vaksinasi, NAT itu sudah terbentuk. Neutralizing antibody already produced by the mother without any vaccination. Regarding to the data from Metis or Kaufman. So my question is, if we vaccine with 120 microgram of RSV, how many times greater the net will be produced by the mother?
You mean the antibody?
Yeah.
Okay, at the moment there's no agreement on the antibody correlate. So you see that there is no, if you look at the studies, no, this is what antibody correlate that it needs to have. There's no agreement among them. Same with Tdap, there's no immune correlate. So, but when the studies say that the antibody transfer is much higher, sometimes more than 10-fold from the mom, from the cord blood, and when they look at the newborn, that's protection. Is that what you answer? You're asking about that?
In the NGM. NGM.
IgM.
NGM, yeah.
IgM, yes.
Yeah.
IgM.
There's already a woman already produced natural
without vaccine.
Without vaccine.
Oh, okay.
So I asked, if we give 120 microgram the RSV, how many the naturalizing antibody will be produced? Because they already have antibody in her body.
Okay. The mother, let's say I get an RSV infection now. I will mount an antibody. But my antibody will go up, then it will come down during the immunologic phase. And this antibody that's come down will not be enough to transfer transplacentally to the vaccine, to the fetus.
I mean, the efficacy is depend on how many amplification of the...
I don't think there is a what do you call that?
The cutoff antibody titer of the RSV. I think there is no agreement for the cut. I think there is no agreement for the cutoff.
Not the cutoff, because before vaccination, the woman already had the antibody itself.
Yes.
From the NGM.
Yes.
You can see the data.
Yes.
So after the vaccination, they will be increasing the level of antibody.
Antibody, yes.
So I mean, if we give the vaccination, what
level?
Level or multiplication we should achieve?
I don't think they can answer that question. They don't have that level. So they don't have the multiplication.
And the next question is, how many concentration of naturalizing antibody needed to avoid any infection of RSV?
Protection effect of antibody
Yeah,
neutralization.
they won't have that. you will have to look at the data. We will have to go back to the data if we have to see. You see, when they give this woman antibody, a vaccine, do they take antibody? They do take antibody for the maternal.
So I mean,
I don't think they did.
Take the example for rubella.
Rubella, yes.
Yeah. If the rubella neutralizing antibody is already achieved 10 or 15 international unit, the woman will be not will be infected by rubella. So hepatitis B also, if anti-HBs is already HBs already 15, so we can say that the woman is already protected by the vaccine.
I don't get it.
Yeah, I think in influenza vaccine, for example, for in influenza vaccine,
Yes.
there is cutoff for hemagglutinin inhibition titer, which is 140 is protective to get influenza. I think
But this one, they don't have the cutoff.
they don't have the cutoff. Yes. Okay.
But the thing is, if you see, you said just now they have the antibody, but we do not know they have the antibody to that particular RSV in the maternal blood. And the vaccine given, so you're saying that this vaccine is like a booster from a natural infection. It's not the antibody rise. If I get an infection alone without the vaccine, the antibody rise will not be long. It will come down. It will be not enough to transfer. Whereas the vaccine will give you much, much more antibody production because it's the immunogenic of the vaccine is much, much more than a natural infection.
Yeah, I understand. But if we know the level of protection,
yeah.
So if there's any biomarker or whatever, we can first to measure the IgG or anything.
Yeah.
To make sure that the level is already achieved. If the level already achieved, I can say to the mother, you need not to be vaccinated because your level is already.
But the question you cannot answer is the level will be achieved at that point.
Yeah.
At that point of taking the blood. Let's say you do the mother and she's 24 weeks. I take the level and she hasn't got a vaccine. I take a level that is high at that point. But that level will come down before she delivers if you don't give her vaccine.
But we can think from the study that the level will be decreasing after 6 months. So if the level...
The level will not decrease after 6 months. The level will decrease quite soon after a few weeks if you don't give a vaccine, because you're talking about natural immunoglobulin. Because you say not giving a vaccine, so I take a level.
Because without any vaccination, there's already antibody.
Yeah, I know, but it's too low to placenta transfer.
So I will ask at what level we need to...
There will be no study who will be able to answer that question.
I think we need further study about that. Maybe Pfizer can facilitate us to do study together.
It will be very expensive to conduct that study.
Thank you. If
my question is very basic, how do you actually classify when the vaccination succeeds to achieve its goal, which is to protect both the pregnant mother and also to the fetus? How do you assess that? Oh, so this one is succeed. To have a final calculations of vaccine efficacy.
You look at the prevalence of that particular incident. So you'll be talking about RSV. So we are talking about RSV burden in infants. So you look at the prevalence of the RSV in that cohort. With maternal immunization, the RSV cohort in infants should come down. So it come down in that cohort. That means that vaccine is working to protect that cohort.
Do you vaccinate all pregnant women or just for the
There would not be a cohort where all the pregnant women will be vaccinated. So that's why you look at the cohort that has been vaccinated, whether in the babies of that woman that has been vaccinated, what is the prevalence of RSV, or for that matter, for any other, like for example, pertussis, say, in terms of prevalence. So that's why you will never get an ethics approval to give you to look at head-to-head. It will not be possible because we are talking about infection here. So in a non-vaccinated cohort, then you will expect the prevalence of that disease will be higher. In a vaccinated cohort, you expect, because this is the objective, so you expect the burden of disease will be lower, and if the burden of disease is there, then you expect the hospitalization, ICU care will be lower, then your inference would be the vaccine is working. So it goes by inference. So the gentleman, the question of the immune correlate be very difficult to achieve, because you can see immune correlate. To do that study, if you look at, there's a lot of study being done on Tdap vaccine. So they would look at the immune correlate, but still there is no immune correlate to say that you reach this immune correlate that is protected. You don't have that. There's no agreement to that. There is no such immune correlate.
So the final goal is to have the number of babies who develop RSV or not, and then you calculate.
Yes. That's why in this Bernie study, they use a case cohort study. Most of vaccine efficacy case cohort. So if you remember Tdap vaccine, there was an outbreak of Tdap in UK in 2012. They initially don't have pertussis. Suddenly there's a pertussis among infants. And then they roll out, before that there was no recommendation of Tdap vaccine in UK. So when there is an outbreak of pertussis, so they now decided to run a roadshow throughout the whole country to vaccinate with Tdap. And they find the next year they didn't have any case, and after that they had only one or two. And then from that inference, they found the inference is the vaccine Tdap was working, and they maintained that vaccine. So if you look at the study in terms of the Baxter study after that, 2 years after Tdap implementation in UK, the same calculation they did. So they look at mother and infant pair, negative pertussis and positive pertussis, then they work back and see which woman had vaccinated, which woman doesn't have vaccinated, and they do a back calculation and to see vaccine efficacy. That's how they do it. Same thing with Tdap. And Tdap, there's a lot of papers on Tdap. So it's going to be the same with RSV.
How long is the default for the mother to have the revaccination?
And revaccination. So because the goal of vaccination in RSV and pertussis is to protect the infant, so they have to have it in every pregnancy. So if you are not... Every pregnancy.
For RSV.
Even in RSV is protection. At the moment, because of the protection of the young, they haven't sort of said, like for Tdap, it's every pregnancy.
Yes, but for RSV, recommendation right now only for one.
At the moment.
Yes, at the moment, yes. No, only one for lifetime. Yes.
But
not every pregnancy at the moment.
But there will be antibody waning, because even in RSV, the antibody will come down.
Yes, because there is no evidence, adequate evidence now to repeat the...
They will wait later.
Yes, wait later.
Pardon?
Well, why they got the result every pregnancy?
In Tdap, because RSV they haven't made that recommendation.
Satu kali aja baru, Prof.
Because it's just newly launched.
Yes, but evidence-nya masih belum jelas.
I think they would still follow similar to pertussis.
I mean, there's the correlation with this.
Pertanyaan Prof Bowo,
Yes, because it's quite similar, because pertussis, the burden of disease is in young infants and newborn, and it's similar to pertussis. But the only difference is now you have the other vaccine for the infants and newborns.
Ya, izin dari Zoom dulu boleh dok ya. There is 3 questions from chat from Dr. Cindy Casti. Dr. Cindy is one of our member. Right now she is in London to get,
In London?
Yes. Yes, in Oxford to finish S2.
PhD.
Udah selesai? Belum kan, baru magister. Yeah, to finish her magister, not yet start from PhD. After magister, she will continue for PhD program. The first question is, you mentioned that in Malaysia, RSV vaccination is recommended between 32 to 36 weeks of gestation. Is there any evidence indicating whether receiving the vaccine at 32 weeks offers better transplacental antibody transfer and fetal protection compared to receiving it at 36 weeks, which is closer to delivery?
When we did the consensus guideline in Malaysia, we started to do the consensus guideline in 2023. So when we had a very comprehensive discussion, there's 1,000 of man hours doing that guideline. So at that time, RSV was not approved yet in our country, but we feel that we had to include it in, and we have enough a body of evidence for tetanus, for influenza, and for pertussis. So when we include it, because at that time the CDC recommend 32 to 36 weeks. When the patient enrolled in the Matisse trial was 24 to 36 weeks. And if you look at the earliest time to delivery from the vaccine is more than 28 days, that is 4 weeks. So the only reason why we had 32 weeks and not earlier, we wanted to do 28 weeks. Because Singapore recommend 32 weeks. And Malaysia and Singapore is just next door. So we don't want to confuse our doctors. So similarly, the TDAP was also the same, 16 weeks, because Singapore was 16 weeks. Now, having said that, when you look at data, whether or not you give the vaccine earlier, should it be more antibody transfer? So when you look at data, the earliest antibody transfer is from 13 weeks onwards. Now, the FcRn receptors, that is the one that transport the antibody IgG across the placenta, is much more produced in the 3rd trimester. In the 2nd trimester, there is FcRn transporter, but not as much. But there was a study by Eberhard and company in 2016 or about looking at the Tdap vaccine. So initially, the Tdap vaccine was recommended from 27 to 36 weeks. But this Eberhard group looked at the study comparing from the early 2nd trimester from 16 to 24 weeks and 24 weeks above to see whether the antibody transfer at birth is similar or not, because it's given earlier and one is given later. So what they find was it was comparable. And in fact, the babies, the mothers who had the vaccine in the earlier had slightly more than the one who had it later. So the explanation would be, even though the transporter is much less at that point, but the duration of transfer is longer. So then that's the same. So having said that, so if you give it earlier, the antibody transfer would still be higher. But why we didn't do it earlier, so I think it's also for us, it's a strategy. Why is it strategy? So we would recommend the tree influenza vaccine in the 1st or 2nd trimester, the Tdap vaccine in the late 2nd trimester or early 2nd trimester, 16 weeks onwards, and the RSV vaccine in the late 3rd trimester, so that the woman doesn't have too many vaccines that they are concerned. So that's why we spread it that way. But I think you can give it earlier, and now data has shown that it is the prevalence of preterm birth is similar. And the time needed to mount an antibody has been clearly studied in 2 weeks. So if you give it at 36 weeks, then the woman might deliver earlier, 37 weeks, so it's not enough antibody transfer to protect the newborn. So that's why the cutoff is 36 weeks.
Yes,
But you should still give if the woman comes to you later.
Yes, I think the question, which one is better, 32 weeks of gestation or 36 weeks of gestation for giving?
32 weeks.
32 weeks of gestation.
Because 36 weeks, there's
yes.
not enough time to build if she deliver early.
Yes.
Because 32 weeks and 36 weeks in terms of the FCN transporter is already increased by that time. By 32 weeks already increased. Okay. So it should mount a higher antibody.
Okay. Continue with your explanation about other vaccines during pregnancy. This is the third question. Is there any data or recommendation on the co-administration of RSV vaccines with other routine maternal vaccines? Is it okay to give one shot?
It should be, yes. Looking, the vaccines are not live vaccines, so it can have be co-administration. So you can have co-administration between influenza and Tdap vaccine. You can have co-administration between Tdap vaccine and RSV vaccine. It's just that you have to have separate arms. So the woman will have left and right arm. So she might not want the vaccine on the same day. But yes, you can have a co-administration because it's not a live vaccine.
And the last question, are there any contraindications for RSV vaccines?
The contraindication would be if they are allergic to the components of the vaccine. That's one of the contraindications. If they are, for example, if they have HIV or they have other, it shouldn't be a contraindication. But if they're allergic to the vaccine components, then yes, it's a contraindication.
Thank you, Prof. Jamia, for your presentation and your all explanation. So although you mentioned that RSV is not pretty new, but I'm not sure whether the healthcare providers in our country and also the society are already acknowledged about this RSV vaccines. So this is going to be a challenge if we want this vaccine to be integrated in the antenatal care services. The question may raise that what is RSV? How important is this vaccine? We never heard any about RSV. So what would you recommend regarding the strategy, both in the personal setting and also the community setting? Thank you.
As OBGYN, I said just now, we don't see any RSV patient because RSV is mainly the burden of disease in infant children. So we won't see in adults. Same like pertussis, we don't see in adult, but doesn't mean the adult doesn't have pertussis because we don't test them, they usually have cough only. So RSV in adults, maybe they just have like flu-like illness, which we will miss as flu. But the burden of disease in the children. And we know that around the world, by the age of 2, almost every children will be exposed to RSV. And that's where the problem is. So the strategy, one of the strategies that I think that's very important, education of healthcare providers, which is OBGYN and OBGYN-related healthcare providers, nurses, midwives, and so on. Because in maternal immunization, the people that the patient will go through is the OBGYN. Of course, initially, maybe not the OBGYN, the primary care or general practitioner. So they need to be educated at the same time. But OBGYN need to be educated because the patient will still reflect to the OBGYN and ask the OBGYN opinion whether it is safe or not. So that's very important. So we need to educate our colleague. Even that's what we're doing in Malaysia for a couple of years. So if I ask my specialist or last year, 2 years ago, RSV, they will ask me, what's that? No, they only learn about it in medical school. They don't know about it. So when the RSV vaccine came, and so we had prepared some educational. So we need to educate. So like this webinar, sharing session is very important because we need to discuss about data, to be comfortable with data. As doctors, we have no choice. We have to relate to some science. Even as doctors, art is important in terms of communication, ethics, trust, and so on. But we still have to relate to some science because that's important, it drives us. So we can still look at the science and sort of discuss on data. So this is where awareness, campaign, society, webinar or KOPI webinar like this is very important as a discussion. And the other thing is consensus guideline, like what you have been doing for the last 2 days, coming into terms, what are the consensus guidelines? Because the society, the OB/GYN society is very important, key in managing all these pregnant mothers in the country. And also I think that's important other than consensus guideline, but to have a social media presence. The social media presence is very powerful in terms of education. TV, radio, social media platform where the patient or the doctors can also participate. So to disseminate information. And of course, the newspaper, magazine are very powerful social, or talk shows, or podcasts are very important. Nowadays, we use a lot of all these online platform to teach. So that's the only strategy. Once people are aware, people are more confident with the data, then of course, then only will come in. I don't expect a buy-in time in the Ministry of Health very soon, even in our country, because it took us 4 or 5 years for us TDAP to get into the antenatal care set. So now TDAP is free for every pregnant mothers if they want it, including illegal immigrants is free, because to reduce the burden, so it has to be free to everybody. So now we will work on the RSV because we don't see the burden, but the pediatric colleague, my pediatric colleagues see the burden. They see a lot of RSV. So that's the only way, education. So maybe, my strategy in Malaysia would be initially in the private market and university market where the patient have to pay out of pocket. When we have more experience, we have more data, then we can drive it to the government, because government will look at dollars and cents. They will not do anything else. So it's dollars and cents. If it's cheap, they say, okay. If it's not cheap, they want to see the pharmacoeconomy, whether it's worth the money spending on it or not. So we have to convince them it's worth the money. So we need data.
Gimana, Dok? Sudah? Mungkin salah satu yang membuat POGI membuat panduan juga yang mengencourage adalah dari pediatrik. Karena mereka melihat seberapa besar masalah RSV ini pada anak. Mungkin kita nggak pernah lihat, tapi mereka yang salah satu minta karena untuk infant belum ada vaksinasinya, hanya monoklonal antibody saja. Is there any other question? Maybe one last question ya?
Do you have also the cost effectiveness study before we launching the program in Malaysia for the, yes?
We have. Same like HPV, we also have cost effectiveness study was done by Professor Al-Junaid. So he's in ministry, but also in UKM. So for the RSV, we are doing one in the midst. We haven't completed yet. So by next year, maybe. So we're looking at RSV cost effectiveness. But for the pertussis, yes, there was one. HPV also there was one. Because that's the only way. Because when you show cost effectiveness to the government, then they will see. If not, very difficult. They will not see it. So we need to do cost effectiveness study. And cost effectiveness study is not easy to do, because you got to cost everything around that particular disease that you are studying. But if you see cost effectiveness, is still cost effective in the vaccine. Because in Malaysia, the pembrolizumab is costing about 20,000 ringgit for 5 doses. That's for the preterm, specific for preterm. So very expensive.
I believe there are still many questions or something that would like to discuss with you, Prof. Jamia, but I also believe that you need rest for tomorrow training. Mungkin kita akhiri pada pertanyaan terakhir tadi, Profesor dan Dokter, karena besok pagi kita masih ada acara lagi. Terima kasih banyak atas partisipasinya. Hah? Oh, okay. Thank you very much, Prof. Jamia, for beautiful discussion.
Cek, ada lagi nggak sih?
Ini ada penutupan. Saya kembalikan ke MC.
Terima kasih saya ucapkan kepada Prof. Jamia dan juga saya ucapkan juga terima kasih kepada Dr. Rima untuk karena telah memandu acara ini sehingga dapat berjalan dengan sangat baik. Sekarang akan ada sesi Oke, baik. Dengan ini rangkaian acara KOPI POGI Understanding RSV Impact in Infants, What Should We Do? Pada hari ini telah selesai. Semoga ilmu dan wawasan yang kita peroleh hari ini membawa berkah dan manfaat bagi kita semua. Sebelum menutup acara ini diinformasikan bahwa webinar KOPI POGI berikutnya akan diadakan pada tanggal 17 Juni 2025, hari Selasa di jam 13.30 sampai dengan 16.30. Selanjutnya, sekiranya kita dapat mengambil foto bersama terlebih dahulu. Baik, saya dan segenap panitia yang bertugas mengucapkan terima kasih. Terima kasih sebanyak-banyaknya. Baik, selanjutnya kita dapat mengambil foto bersama terlebih dahulu. Untuk profesor, doktor, dan dokter, dimohon boleh bersiap untuk mengambil foto. Boleh lihat ke kamera? Iya, ke kamera sebelah sini. Iya. Nanti bergantian ya, Profesor Dokter. Oke, saya babakan. Ya, 1, 2, 3. Oke, satu kali lagi. 1, 2. Ya. Oke, 1, 2, 3. Yang sebelah sini boleh? Iya. Oke, bersiap. Saya babakan 1, 2, dan 3. Ya, sekali lagi. 1, 2, 3. Oke. Terima kasih banyak.
Baik, terima kasih. Kita beri aplaus dulu ke Prof. Jamia. Terima kasih pada Pfizer yang sudah menjadi sponsor pada malam hari ini. Baik, boleh ditutup untuk KOPI POGI-nya. Kita masih ada satu acara lagi. Ini adalah presentasi dari PT Kalbe. Ya. Akan menjadi sponsor untuk di Aceh nanti katanya. Jadi harus didengar. Jadi saya persilakan untuk PT Kalbe memberikan presentasinya.